Well, as a person with Parkinson's, sometimes you're fending for yourself on side issues, and that's what's been happening with the wound, and it's been a long process. So I thought I'd give you a little more details on that. But also, I wanted to say that over the period of time, I have driven to Fayetteville and had a pacemaker put in and driven back. And I went to Little Rock where I had the device put in my back to control the spinal cord stimulator. And my daughter went with me, but she had a driver's license, but she didn't drive, but she could be recorded as my driver. So I have done a lot of things independently, and I know that there's times that somebody might have helped, but it's the way it's been, and down here that's happened several times, and people get concerned about what I can do independently, whether I can drive or not, whether I've taken the test here through Baptist Hospital where, I passed all the tests. So people have concerns that are not merited, so I'm trying to get
in
that
arteries or blood vessels of the legs. The condition can restrict blood flow and lead to complications.
PAD not only influences our ability to walk, but it puts us at a risk for amputation, and then also that tie-in with heart attack and stroke because of that systemic cholesterol buildup.
Diagnosing peripheral artery disease starts by checking circulation to the feet.
Taking off the shoes and socks, doing a foot exam, feeling the pulses.
An ankle brachial index test can identify circulation issues by comparing blood pressure in a person's ankle to that in their arm before and after exercise. Tests and time with a healthcare team can promote conversations about the most appropriate medical treatment.
Not only things that we typically think of, like cholesterol medications such as statins or the role of aspirin, but some of the other medications to help reduce that future risk.
For the Mayo Clinic News Network, I'm Alex Ositis.
September is Peripheral Artery Disease Awareness Month. PAD is a disease caused by plaque buildup in the peripheral arteries. It can reduce blood flow to the legs and feet, often leading to lower limb amputation.
The American Heart Association reports that the amputation rate in Arkansas is higher than the national average, significantly so. At nearly 68%, it beats the national average by more than 20 points. Spoke to Dr. Gary Allen, a vascular intervention radiologist and PAD specialist in Little Rock, and he offers tips on some common signs and symptoms of PAD to look out for.
Well, Dr. Allen, thanks so much for joining us today on Little Rock ARC. We appreciate your time.
Thank you.
And so we know September is PAD Awareness Month. For Arkansans that may not know what that is, explain what that disease is.
Yes, PAD stands for peripheral arterial disease or peripheral vascular disease, which is hardening of the arteries, plaque buildup in the arteries that all of us get to some degree as we get older, but there is certainly certain things and people that are more susceptible to it, that when it causes blockages of the arteries, it can be quite serious and devastating on what part of the body that is involved with. So as we know, the arteries take the blood flow to places, the veins bring it back, and in the lower extremities, arteries take the blood flow down to the legs and feet, and so that's very important for wound healing and for pain with walking and that type of thing. Again, it can happen all over the body, so the heart can be involved, the blood vessels of the head and neck can be involved, and can be pretty serious consequences of those things, of blocked arteries.
And what are some of the consequences that people need to be aware of?
Yeah, so for peripheral vascular disease, it can cause strokes, or also called TIAs, which are small mini strokes. In the lower extremities is what we work on here at PAD Specialists. Common symptoms would be walking and not being able to walk very far because your muscles begin to hurt, begin to cramp. More serious consequences would be wounds that are not healing, particularly in diabetics. Other things would be ischemic pain, just pain all the time in the lower legs and feet with discoloration and as it progresses, can end up being wounds that do not heal,
And
which could lead to amputations. Yes.
And I was just about to ask you if there was a connection between lower limb amputation and PAD.
Yes, very much so. That is probably the most common cause of a non-traumatic amputation is peripheral vascular disease that becomes so severe that there's no blood flow, turns into gangrene where toes need to be amputated, and then serious enough to where the leg needs to be amputated. And of course, that can be very devastating to patients depending on their age and their current mobility of how they are. So it can be very much communication there.
And how does Arkansas look in terms of numbers for PAD in both lower limb amputation?
We're not very good. We're one of the top states that has the most major amputations in it. There are a lot of southern states as well: Arkansas, Alabama, Mississippi, and we need to do better than that. And that's what there's a lot of good physicians here in Arkansas that treat this type of thing. And we need just to make patients aware of it, the early signs of it, so it can be caught early and try to prevent these things from happening.
And why do you think so many southern states are impacted by PAD?
Yeah, some of it's just the demographics. We don't eat as well as we should here. Again, it goes back to a lot of the risk factors. Those being diabetes is one of the biggest ones, and then smoking. Even if you used to previously smoke, the damage could be done, and it can be quite a problem to help that. So.
And what does treatment for PAD look like?
Yeah, there's several treatment options. Well, the main one is the one we try to do first, which is we call endovascular therapy, where we go in with a catheter. And I know most people have probably heard of balloon angioplasty, where you're angioplasting the vessel open. So we go in with a small catheter. There's ways we can clean the plaque out called atherectomy, where we can clean the plaque out, and then you can angioplasty it to help open the blood vessel. And then we do some stenting if needed. If that type of treatment is not as effective, we sometimes will stent the blood vessel open. If in certain cases where the blockages are so bad, some people do need surgical bypass procedures, which would be done in a hospital where the blood vessel is completely bypassed. And there's a lot of patients that are not candidates for that, particularly if we're way down in the feet, ankles, below the calf and in the feet. There's just not a way to bypass those blood vessels. So we rely on our techniques of going in and opening those blood vessels all the way up into the feet to heal wounds and to relieve ischemic pain.
And as our viewers are listening to this at home, if they're thinking, themselves or a loved one may be affected by PAD, what do they need to do?
Yes, certainly go to your primary care doctor first. They certainly will know a lot of the signs and symptoms of peripheral vascular disease, and there's tests that can be done, non-invasive tests with like an ultrasound or just listening for the pulses, and them doing an exam could certainly tell if they have potentially have PAD.
And as we wrap up, can you just reiterate those signs and symptoms one more time for our viewers?
Sure. We kind of start with the most minor symptoms, which would be, just pain in the legs. A lot of times with walking, where you walk a certain distance and then you start to have pain in your legs, particularly your muscles of your thighs and your calf, and then you have to stop because you can't go any further, because that's a narrowing of the blood vessels, not allowing that extra blood that you need to get to the muscles while you're walking. And then so the muscle cramps up. That would be some of the earliest signs. As it becomes worse, begin to have ischemic pain where the leg hurts you all the time and then becomes discolored, red or even blue, which would be extremely severe. And then the worst, just when we start to have loss of tissue, where a toe turns gangrenous, or a wound is just not healing because the blood flow is not getting there.
Right, Dr. Allen, thanks so much for joining us today.
You're welcome.
And some of that insight with us. We appreciate it.
You're welcome. Thank you.
Yes, I want to use this podcast to reflect on some of the technical aspects of what I've been experiencing. Of course, I think it's been obvious that I have Parkinson's disease, and I have been dealing with some other issues along with Parkinson's. A couple of pretty severe foot wounds that are kind of concentrated on the heel area of both feet. So I wanted to make sure that you understood maybe some of the complications that's come about there and why I'm kind of updating it to this point. One of the things that you've noticed, I've been to a kidney doctor, urology. I saw a cardiologist at the hospital when I was in special care at St. Vincent's, and of course with the foot wound clinic, I go there regularly on a weekly basis, and it has a range of things that I deal with there, and the others on various levels that I work with, depending on what the situations, what develops, and it makes it pretty complicated. When I get the big picture, a little more so from Dr. Dean and maybe others at the wound clinic, because he had a history of being a heart surgeon, so he knows a lot more about the total picture of circulation, whether it's with your blood or other situations might develop. Well, there's a thing that's called PAD. It's a peripheral arterial disease that has to do with when your veins and arteries get kind of plugged up, and you're trying to figure out ways to unplug those before they do much damage to your feet or your legs. And it's the genesis of a lot of problems, and sometimes you do therapy, and you really don't solve the problem. You might fix it for a period of time, but you have to eventually figure out where the genesis of the problem is. And then you find there's a lot of complications there, because in my case, I had a high level of creatinine, which is dealing with my kidney, and I had some issues with the heart, and fluid building up there. And so you're in a short period of time. They say people diagnosed with a PAD it can be a 5-year period in which they either maybe were killed by a heart attack or a stroke or some other complication there, or just the amputation. As I've shown before, you could see very easily where the wounds could develop into amputations at a fairly fast pace. So that, along with dealing with some of the other things you deal with Parkinson's, complicates the matter, particularly when you're talking to people. They focus on the Parkinson's, and you're trying to do some things to solve other problems, and sometimes they misunderstand you. And it's kind of funny. I was reading something that maybe is a communication I had with my son, and he put it in terms of they being mean to me or something. That wasn't the case at all. It's just the understanding of each other when you're trying to communicate, and they don't really see the big picture. I want to kind of start on that level and show you a little, few things that you can look for. I mean, this might be you, might be a friend, might be part of the family, but there are a lot of issues where people kind of disassociate, or they want to hand it off. I know we had that opportunity with our daughter when we found she had a orofacial digital syndrome, but we maintained the idea that we were probably the best to raise her, and I think that was the case. And I don't want to belittle anything that Sandy did on that, because she's been there all the time, and she's definitely there now to take care of it, and so I'm not wanting to be part of the problem. I'm trying to stay separately and deal with this independently. And you'll see how I've done this all my life. It's not a big deal. Some people think, well, he can't do this, he can't do that. And then they don't think about some of the things we've done in the past. You don't take a small rural company and take it globally by having all the negatives override the positives. And you can think about all the things that will go wrong versus having something go right. So that's the only thing I want to make sure. There's an understanding there from an entrepreneur and technology person that might be a little different than others that want to give up. And they say, why are you continuing to do this? And some of it may not be for my benefit. Some people might watch some of my podcasts and have a better understanding of where I was and where I got to. And others may see it and see that it's it's kind of like one doctor was talking about, but maybe he ought to be a marriage counselor because a lot of the issues started coming up to be social and just interacting with people and family and friends where they may have expected you to be an introvert, and then you start acting a little differently and more of an extrovert, and they say, how do we deal with this guy? And then you find out that mentally he comes across well as far as any tests or any checkouts or any other things. He got some obvious physical problems, and so we're not trying to minimize those. But sometimes people have a tendency to, to match those up. I mean, I guess they see a Michael J. Fox, and they know there's the tremors and a lot of other obvious things that may not be with everybody with Parkinson's. And one person says, if you've seen one person with Parkinson's, you've seen one person with Parkinson's. And that's why it gets complicated. And that's why I want to tell this story where I can communicate it. It's good for me, for my skills. It's good for people who are interested. And if you're not interested, that's the nice thing of being on the internet or on a video is you can either skip past the parts that you don't want to watch, or you can see that some of the pieces I put together are real small snippets. They could be TikTok, or they could be just little small videos or something a little more with clarity over something that's stretched out. So I'll leave it at that, but that's really where we are today. I think when you hear about the procedure, you think, well, it's a simple procedure, and they put this tube down you, and they balloon it and clear the flak out. Well, the elapsed time on this was, I don't know, I went in about 11, and I think some of the things I see here are 4 o'clock in the afternoon, so it was a long period of time, and Dr. Allen did a great job, but no doubt that it was over 3 hours that he was in there trying to get this flak removed, and he's an excellent doctor. But I wanted to get the recording of the nurse that kind of recapped it. As you can imagine, when you're out that long, when the doctor comes in and explains it, it's pretty blurry. And still, as you can tell by my speech and everything, that it was still a point where it was very difficult to communicate. But I thought it at least gave you an idea of what was going on there, along with what you've already seen about this procedure.
How the blockage was, or where it was, or...
Well, sometimes like you just don't know how, like you don't know how bad the blockages are. Sometimes you may have a wound on one side and you may have like a minor wound on the other. It just kind of depends. Everybody's body does it a little bit differently. And sometimes, we can go in there and start messing around with stuff, and then other things can become like a little bit occluded. Got this stuff all over you.
Was the, I guess, a blockage in the sense that, was it...
So there's 3 arteries that run down your leg.
Okay.
Well, so there's one. So it splits at your belly button and forms into 2. Okay? That's what your diagram looks like. So it comes down here to your knee, And then behind your knee, it kind of splits off into 3. After it goes behind your knee, it splits off into your front, which is your anterior tibial, your back, which is your posterior tibial, or your peroneal, which is the one that comes down the middle.
Yeah.
Okay? So the one that feeds the heel, kind of feeds the heel and up towards the bottom of the foot, that's your posterior tibial. So, and that comes down into this little dotted section right here is the pedal loop, or lateral plantar. So that artery runs center of the foot. Okay, so when he got in there today, he discovered that this entire artery down the back part of your leg that feeds your heel and the base of your foot was completely blocked.
Well, okay.
Okay, so what he did when he went in there is instead of just going in and like ballooning it open, so we put that balloon in and kind of inflate the balloon and pushes that plaque to the side, he ended up doing an arthrectomy, which I think they did on the other leg also, where they go in and use that laser and that little Dremel to kind of roto-rooter and clean out the pipes. So that's what he did to get all this cleared out and then into the base of your foot.
Okay, so what will I notice from that?
So it may take a couple of days for the wound to start getting better. It may take a couple of weeks, but since you've got that improved blood flow down there now, you should start getting those nutrients and oxygen and all that stuff that's going to help it heal. Because the other 2 arteries feed the top of your foot in the middle. So when you got a wound on your heel, if you don't have adequate collaterals and this one on the back is clogged off, then it's not going to get what it needs to heal.
Yeah.
So that's why he went in and cleaned this one out today.
Yeah, I didn't know whether you see a lot of blood, or do you see I don't know what the appearance is to him when it clears up.
It's plaque. It's like little fat deposits that deposit just like they can deposit on your heart, they can deposit in your arteries. So it's not a blood clot where we could kind of dissolve it with a blood thinner. It's thick plaque that kind of develops over time.
Yeah.
And everybody gets it to some extent, but some of us tend to get a little bit more of it. Things that typically make that worse are smoking, diabetes, high cholesterol, high blood pressure. Those things kind of accelerate the disease process. And that's what can make it worse. But most people don't know they have an issue unless they get pain in their legs or they get a wound.
Okay. If you have neuropathy and diabetic, then you don't feel it. Sometimes you don't know it or you don't feel it as worse.
Right.
So that was the other question.
Yeah, so sometimes that's how you get the wound the first time is because you can't really feel it. Okay? So we'll have you come back and see us in clinic because that should help your foot. Should help the back of your leg and your foot on the right side, okay?
Right.
Okay.
Did it help my foot in since the healing of the wound?
Yeah, it should help. Well, it should help a lot of things. It should help the healing of the wound.
Mm-hmm.
It's not going to heal your neuropathy, but it may make it a little bit better because now you've got blood flow down there to those nerves and stuff. But ideally, the focus is we want to make sure we can get these wounds getting better.
Yeah. And as far as my existing one, been on the left side, we already had this procedure done on. I guess the thing there is, and I guess you can't tell much about that, but on the left side, but I guess they look at it whenever they do the thing with a boot or shoe, so that they can see. I'm wondering, at this point, what amount of pressure do you put on the right foot in the situation we're in? Is it just something I don't put much pressure on, or does it matter, or what is it?
Well, in theory, you don't really want to put too much pressure on either one until they're both healed.
Yeah. I've got shoes that are supposed to keep more of the pressure on the front part of the foot anyway, but it's okay. It should be okay to be doing more as far as any just what I've been doing, but just avoiding anything that would put pressure on the heel or keep it off the heel, I guess, at this point.
Yeah. Just try not to keep that pressure on there, especially like if you're laying in bed, if you can prop your legs up so they're not in contact with the mattress.
If you are, maybe if when I sleep, I lot of times on the right side, just the way I've normally done things. I don't know, is it better for all this to be on your back to sleep all the time, or does it matter?
It doesn't matter. Okay. Whatever's comfortable for you.
Okay, so I don't have a problem with having to, sometimes that's when you start having trouble getting your breath and everything. I mean, you know, just normally, that's the way I've always adjusted to it, so that's good. But did it look pretty serious in the sense it sounded like it was blocked? It was pretty...
It was blocked, but he got in there and cleaned it all out.
Yeah, but I mean, that in itself could cause a lot more damage or more wound or more, just because it didn't, wasn't clean where you could heal, I guess, or I mean, it sounded like it would be serious enough to prevent a lot of other things from happening.
Yeah, I mean, it was preventing you from healing.
Yeah, so the healing part of it might be improved quite a bit, it sounds like. Yeah. What I was trying to think about is what the bottom line is. And as far as doing anything or activity, right now, just stay off of it as much as possible. Or
yeah, I mean, you're going to have to stay off of it for a couple days because we went through your groin for that access site.
Yeah.
So you're going to have to kind of take it easy and not do too much aggressive, like physical therapy or anything.
That's what I want to make sure that I don't know if I get any kind of orders or anything that further I pass on to the therapist there.
Just, I mean, like no physical therapy with weights, like as far as like putting pressure on your groin for a couple days.
Okay.
But we're going to send you the discharge instructions that I'm going to send you with. She can look over those too. And she'll have like a better idea of what she can and can't do with you. Just trying to figure out. It says there's a leak.
No, what?
It says there's a leak.
Okay. You were talking about a leak over there on that right foot then.
I'm trying to figure out where the leak maybe is.
Well, there's been one thing where they had broke loose at one time, and they tried to do a tape thing, and
well, we'll see if we can fix it a little bit. I don't know if I can.
Well, I mean, there's some nurses, people can look at it.
When you get there?
Yeah, at the you know. But then again, I go see the wound clinic on Wednesday.
Yeah.
So it's all kind of lined up to kind of follow up there, plus at the wound clinic, and that kind of. But you know, you always felt like that some of the issues were because of this blockage or whatever it is that might have.
Yeah, I mean, the reason your wounds aren't healing is because they're blocked.
Yeah.
Like, by getting those blockages out, your wounds should start to look better.
Okay.
They should start to slowly kind of heal and start looking significantly better.
Well, that's what we're going to do,
So.
I don't know about the pain or whatever comes out of something like this, but.
So you shouldn't really have too much pain.
Okay.
You may have a little bit of soreness, like in your groin area where we actually went in.
Yeah.
You may have a little bit of soreness down in that leg, but you shouldn't have any type of excruciating pain, not anything super.
So, back in the rehab, you can see I was there by myself, but that's okay. And started hearing noise from the wound vac, which I had heard when I was over there previously, so you can see what I have to deal with.
You're the appeal nurse, or what are you saying?
Yeah, I give medicine every morning.
Okay, so, I mean, that one there probably got stretched out when it fell off the end of the bed. And, I mean, I don't think it's critical till in the morning.
Yeah, you have to put your feet back up with this thing.
I don't have a problem doing that.
Why?
Well, when it stretched out and fell off over here, it pulled it out. And I couldn't get to it.
No, I'm talking about if you put your feet back up here, this can stay over here.
Oh, well, it's not the best place for it to be. I don't see anything that you can help me with, really.
No, I can't.
So
If you're gonna stay like that, you're gonna drop it and break it.
Yeah.
When you get ready to go to bed, let us know.
Okay, well, thanks for helping.
That's where I come here. I thought I'd get the best professional I could.
Well, I just treat your legs and your wounds.
You think it's a mental thing?
Well, I don't know if you need a priest, a lawyer, a financial counselor.
Well, we got about all those.
I know you need a doctor. Your wife called today and expressed her feelings.
Well, what was she saying?
I don't know that she realizes that my relationship is with you, and it's totally about your care, not about her comfort.
I know.
And she was saying she would be much happier if you would just accept Medicaid and live in the nursing home.
Yeah, I know. She wants to put.
And she wants you to live in Hickory Heights, and so that you can ride your scooter over to visit your daughter. Is it that close? Is it really close to your home?
It's a 10th of a mile. That's around the corner. And it's really not a bad deal.
And she said, we just have no money, but people that live in Hickory Heights, that generally is not the case.
Well, I know. And or lower in Village. I mean, there's a combination of money that's out there, but you know, it's from a lot of stuff from past. And I know that she's concerned. I showed a video the other night of when they came in. The one thing fell off the end, and you know, I just wanted them to pull it around and so I could look at the thing, and we got into almost a fight because it was stretching the tube out, and I just needed to go to the urine, you know. And
yeah, she said you're narcissistic while she's telling you to go on Medicaid and live in a nursing home.
I know.
So to me, that's the pot calling the kettle black.
Yeah, well. No, we're in that cycle, but.
Has Ryan rethinking a complicated relationship with his own dad, James, who died in 2015 after a 20-year battle with Parkinson's disease. Parkinson's affects an estimated 1 million Americans, including Michael J. Fox and my father, Bill Geist.
I was reading through your dad's story, and my gosh, is it almost shot for shot our story, which is diagnosed at a pretty young age.
Yeah,
my
your dad was 47,
47, yeah, and denial for a long time.
Yeah.
In fact, we didn't name it for a long time.
No. And that might have said Parkinson's, I think, 3 times
Wow.
in his entire life, to me. It wasn't until very late into my father's battle that I even knew hallucinations and delusions were common in people with Parkinson's.
Today, Ryan, alongside his mother Tammy, is partnering with Acadia Pharmaceuticals to raise awareness about some lesser-known warning signs of Parkinson's.
Jim came home from a trip, and he was convinced I'd been in the car with him. I was not in the car.
Reynolds' dad, among the 50% of Parkinson's patients who experience delusions and hallucinations, says neurologist Dr. Daniel Kremens.
People think of Parkinson's disease as just like a motor disease where they have a little bit of tremor or maybe some slowness or difficulty walking, but Parkinson's disease is so much more complicated than that.
I just kind of cast it as, oh, he's losing his marbles. Had I known, I think I would have handled it better. I think I would have been a much more patient person. I think my father would have felt way less alone.
In his father's final months, a moment of joy.
He met your first child, right?
He met my daughter, James.
Yes.
It's named for him.
So you got that pleasure.
Yeah, and I love that she got to meet him. Granddaughters would have really changed him.
Yeah, right. Softens you right up.
Yeah.
Wow.